Uh, Good afternoon, everybody. Thank you, Madam Chairman. And I have no financial interest. When a young cataract surgeon thinks of glaucoma, he certainly feels that why should I not do surgery? And he feels surgery. But glaucoma surgery has its own complications. The moment he sees AC flat on day one, he starts looking like this and starts contacting his seniors. So, why flat AC is so scary? It is because of two main things, a leak and a malignant glaucoma fear. So, what is an ideal post operative day 1 or day 2 appearance? Slightly shallow AC, IOP 6 to 10, no leak, no irritating sutures, no touch, no hyphema, well formed bleb, and a visible PI. So, this is the appearance of early and late ideal cases. So post-trap flat AC, the causes can be with elevated IOP or without elevated IOP with low IOP. The ciliary block glaucoma is with elevated IOP is the most dangerous. Suprachoroidal hemorrhage is very rare. Retained visco can occasionally be a cause of slightly on the higher side of IOP. With low IOP, it's the overfiltration, wound leak, choroidal detachment, and aqueous hyposecretion, which can be because of inflammation, ciliary body detachment, cyclodialysis, and the use of aqueous suppressants, as Dr. Das told in the beginning. So, first and foremost is the flat AC with low IOP. The confirmation of diagnosis is possible by UBM, but we mostly don't do it in the early post-operative period. The incidence is increased because of antifibrotic agents and is decreased because of releasable sutures, both of which are now becoming common. So the three grades have been described. Grade 1 is when there is a peripheral iridocorneal touch. Grade 2 when there is a sphincter touch. Both these are generally managed conservatively, and grade 3 is an iridolenticular or vitreous touch, which is a surgical emergency, and you can't even wait for the patient to be taken to the OT. You have to write then and there wherever you see this patient. So it can lead to, this is why it is such a big emergency. It is because it can lead to cataract formation, anterior and posterior synechial formation, as well as endothelial cell decompensation in hours, not in days. So the treatment is AC reformation with air in case of leak and viscoelastic in case of overfiltration. Because overfiltration needs more time to settle, and if there is a leak, if you put viscoelastic, then the healing will not take place. And this is to be done right in the clinic itself. And resuturing and further management is possible only when the OT and the surgeon are available for that purpose. And this is a case of bleb leak, which you can see that here is IOP is generally very low, and AC may be flat or shallow, and the bleb is shallow or flat. The diagnosis is confirmed by Seidel test, which you have just now seen in the video. And the moisture flow strip is applied here in the area of suspected DEET, and flow of aqueous can be seen as a grain flow in the blue light. The site is generally a conjunctival suture or an area of conjunctival buttonhole. The treatment, we start with a conservative treatment by use of stopping the steroids, starting gentamicin, strong cycloplegia, pad and bandage, large bandage contact lens, autologous blood, so on and so forth. So many other things have also been tried. The definite treatment may be by laser or by surgery. In laser, we can use a per string sort of a system, and we can use large spots, and we can, but before using this argon laser, we have to use a dye, because otherwise the energy will not be taken up. The suture removal sometimes can be helpful, because there can be a suture which is the cause of the trouble and is the cause of leakage, and you remove the suture and leakage stops after a pad and bandage for 24 hours. Most commonly, it requires resuturing, or sometimes the distal edge of the conjunctiva has retracted. So for this, we remove the corneal epithelium before suturing it to cornea, otherwise the healing will not take place. It may require lens removal if the cataract has already formed and the shallowness persists. So this is a case of rapidly formed cataract because of iridolenticular touch. The problems related to black leak include blood failure by multiple means, which I shall not go into details because of paucity of time. And all these things ultimately lead to trabeculectomy. The hypotonic maculopathy is common more often with overfiltration if it persists for long, and the risk of infection is always there in a case of leak and leading to endophthalmitis. This is autologous blood injection as one of the treatments for overfiltration. Hypotony due to overfiltration, here the bleb is highly raised and not flat. In bleb leak, the bleb is flat. So this is the difference, and relatively innocuous and settles on its own in a few days or weeks. And make sure there is no leak, because there may be a leak somewhere else and there is a cyst formation somewhere else. And it can cause significant hypotonic maculopathy if it remains for long. Generally, it happens if it remains for few months. Hypotonic maculopathy is more common in this, and grade 3 shallowness is, however, very rare. So this is a case of overfiltration showing a large bleb and a relatively shallow AC. The management is mostly conservative, and stabilization of the black aqueous barrier by using cycloplegia at steroids may need intracameral use of viscoelastic and may require Palmberg sutures. And argon laser photocoagulation from the sides can be done if the extent of bleb is more than 3 to 4 o'clocks. And if not the surgical tightening, if none of these things help, then you have to do the tightening of the scleral flap, which may lead to ultimately again the filtration failure. This is a Palmberg suture, in which you can see the books to understand how it is done. The ciliary choroidal detachment is the third most common cause, and it may be a cause, or but more likely as an effect of hypotony. Even if per operative, intraoperative hypotony of 10-15 seconds can lead to ciliary detachment and shallow AC postoperatively. It may be subtle and hardly visible on even on UBM to an extent of kissing choroidal. So extent can be wide. The reduced visual acuity may be an early sign and generally settles on its own with a conservative treatment with cycloplegia. If it does not settle in 2 weeks, then AC reformation is required. Flat AC with elevated IOP, the causes are generally pupil block, which is uncommon. Malignant is the most difficult thing that we are scared of, and suprachoroidal hemorrhage, as I said, is rare. It is expected in the first 3 days, and expected IOP in the AC if the AC is shallow. If it is due to leak, the IOP will certainly be less than 6. So a normal IOP of 13, 14, 15 may also be a malignant glaucoma. And this also is known as ciliary block glaucoma, and is more likely in cases of chronic angle glaucoma when there is no patent PI. If one eye has suffered from this, then the other eye is likely to have the same problem, and preventive measures may be required. And the treatment for this is mainly cycloplegics, which may be required lifelong following this complication. And reform AC if there is no in 3 to 4 days, and the treatment can be by lasers, or further treatment can be by surgical. Here basically you have to break the anterior face of the vitreous by various means, whatever means are available. And the aqueous pockets may be visible ultrasound, but usually are not. So this is a case of ciliary block glaucoma post cataract. I don't have a picture post trabeculectomy, and this is a very, very shallow AC, as you can see, which has become all right with anterior laser hyalodot-P. Thus, to summarize, post of flat AC is a serious complication of incisional surgery for glaucoma. Mostly one of the 4 reasons are there, and IOP decides whether it is malignant glaucoma or otherwise. Most cases can be managed conservatively. Iridolenticular cataract is a surgical emergency. This is contact. Although YLC, that is capsulotomy with anterior face, may help in pseudo fakes, the vitrectomy may be required for malignant glaucoma. Eyes with malignant glaucoma may require lifelong atropine, and the fellow eye needs to be taken care of. Thank you so much for this opportunity, and thank you, Dr. Parul and AIS.